Good afternoon. Thank you for your interest in my presentation, Accounting for Perceptions of Stigma, Silence, and Misunderstanding in Suicide Survival Narratives. I'm Taylor Binnix. My background is in sociology with a focus on suicide and mental health. And at present, I'm a candidate for the Master of Public Health degree from the Johns Hopkins Bloomberg School of Public Health. First, let me share about the magnitude of suicide as a public health problem. These data are taken from the Preventing Suicide as a Global Initiative report from the World Health Organization in 2014. Suicide is a major public health problem in every country and every community worldwide. As of 2014, suicide was the 15th leading cause of death, causing 1.4 of all deaths. The global age standardized suicide rate is 11.4 deaths per 100,000 in the global population. In addition, according to self-reports, there are 4 suicide attempts per 100 adults globally. This means that for each adult who died by suicide, there were likely 20 others who made 1 or more suicide attempts on their own life. I'm here to address a new agenda for suicide research. It is timely and imperative to address the sociocultural factors contributing to feelings of suicide so that we may work to make a dent in this huge economic, social, and psychological burden for individuals, families, and communities across the globe. My project aims to understand suicidality from the perspective of people with lived experiences being suicidal. Furthermore, I aim to address the dearth of qualitative research in suicide by using a mixed methods and qualitative informed approach. I'm presenting it today for the American Association of Behavioral and Social Sciences because my work is largely informed by the seminal theories on suicide from Emil Durkheim in 1951, as well as Erving Goffman's theory of stigma published in 1963. My aim is that this qualitative project will contribute to conceptually advancing what is known about suicide and suicide stigma, so that as a field, we may better understand how to prevent suicide. There are several main objectives that I have for this project. First, I'd like to understand how formerly suicidal individuals perceived the reactions of others during their times of suicidal crises. I rely on the voices of those who have lived experience with suicidality to share their perspectives and understand the roles of significant others in the development and recovery of suicidal experiences. It is my hope that accounting for the role of others in the interplay and coalescing of factors contributing to suicide is that we will identify nuggets that can be used for targeted prevention, intervention, and postvention efforts for addressing suicidality in the world. To do this, I conducted a qualitative project. I conducted 20 in-depth, semi-structured interviews with adults that lasted for 60 to 90 minutes each. I connected with my participants in person or over the phone, and I digitally recorded our conversations. Then I transcribed the interviews and redacted all identifying details. Any pseudonyms associated with this project are anonymous to protect the privacy, anonymity, and confidentiality of my respondents. In the analysis phase, I used a grounded theory, open coding process, and QSR in vivo 10 software to identify notable recurring themes that arose as the most salient from my respondents. I included 20 interviews in my sample. Volunteers connected with me through word of mouth advertising and snowball sampling techniques when they self-identified as formerly suicidal. Of the 20 adults that I interviewed, they ranged from 22 to 65 years of age, and they predominantly identified as female and were majority white respondents. At the outset of my study, I expected to have discrete themes that could be used to strategize about targeted interventions for preventing suicidality. Yet, what I found was 3 dialectically interconnected themes that served to perpetually reinforce the suicidal cycle and the responses from social others. In this section, I present on the complex interplay between stigma, silence, and misunderstanding that create a dialectical web reinforcing social cultural beliefs about suicide and suicidal experiences. We'll start with stigma. All 20 participants reported feeling stigma around their suicidality at least 2 or more times during their interviews. 70% of the respondents made reference to stigma 10 or more times during the interviews, which was an average of a stigma reference every 6 to 9 minutes during the interview process. Participants expressed feeling discriminated against, judged, excluded, or devalued by everyone from family members to housing authority to medical personnel, university staff, coworkers, and even mental health practitioners. In fact, this is a quote from a respondent who worked in the mental health field at the time of their suicidal crisis. In the interview, this person shared with me the following. I was working in the mental health field at the time. I had mental health professionals working all around me, in their cubicles, talking on the phone, and handling the occasional suicidal call. I knew that if I went to someone in my field and said, I'm suicidal, they would pick up the phone and call, and I would be committed or fired or something like that. Clearly, you don't just say that you're suicidal. It's still challenging to be able to talk about. This participant is referencing the magnetized sense of stigma that they felt within their own field. While colleagues were interacting with suicidal patients, this person felt as if they had nowhere to turn, and they were rendered silent, keeping their suicidality inside themselves and not being able to seek support. In fact, 13 participants claimed that the stigma around the suicidality at times rendered them silent or silenced about their suicidal experiences. They claimed to discuss their suicidality with significant others less or not at all because of the fear of how another person would respond to them. Participants described this silence around suicidality with language such as getting cut off, feeling minimized, someone else changing the subject, brushing it under the rug, or forgetting that it even happened. Here's one participant who described how feeling silent reinforced their own suicidality in a perpetual negative loop. This person said, I think that it has to be one of the major features of being suicidal. It is essentially a lonely business. If it scares you, then you don't tell people about it. And then that isolates you further. And then that contributes to the fear and you wanting to isolate yourself. You don't want other people to feel the fear, so you just take it on yourself. It's like, I don't want to freak everybody else out because I'm freaked out. This participant quote really captures the reinforcing loop of how the silence contributed to their feelings of suicidality in the midst of their crisis without knowing where to turn for help or being afraid of reaching out to significant others for help. Lastly, there's the misunderstanding surrounding attitudes, the misunderstanding that typifies the attitudes and beliefs surrounding suicidality. All 20 participants reported feeling misunderstood about their suicidal experiences. I use misunderstanding as an umbrella term to reference any type of communication failure about describing their suicidal experiences or feeling as though they were heard or understood. Participants reported as though they felt that others could not comprehend or didn't understand or oversimplified what it was like for them to be suicidal. Prior research has described attitudes around suicide as selfish or weak. But yet here I share 2 quotes from participants who identified that as a misunderstanding. The first participant said, "I kept thinking, I love my family, and I hate the fact that I have to do this to my family, but it's something I need to do. It was something I needed to do. I felt like I needed to do it. People say, yeah, well, it was a selfish move." And I'm like, no, it was a very difficult move. Here, the participant makes a direct call out to selfish attitudes around suicidality, indicating that they were in fact thinking about their family members at the time of their suicide attempt and referencing that they were driven by an intense, deep-seated need. Another participant says, the second quote, "I've heard the comment, oh, they're only seeking attention, but my argument is, so what? The person is crying out for help. Why is attention seeking so devalued?" This participant quote directly identifies the gap for public mental health services that could have supported this participant in advance of reaching the time of crisis. Taken together, the stigma, silence, and misunderstanding comprise a complex belief system which served participants in accounting for their experiences with suicidality and what happened in the aftermath of their suicidal crises. These participants are in fact very well informed about the effects that stigma had on their own suicidal experiences and the silence with which they were treated and the misunderstandings with which they were confronted. By elevating the voices of those with lived experience with suicidality, I aim to elucidate the meaningfulness and trends that we can contribute, highlighting interpersonal difficulties, relationship disruptions, employment disruptions, family conflict, in the hopes to identify barriers and opportunities for seeking help so that we can learn from these experiences by way of informing future attempts, future interventions to prevent suicide attempts. Ultimately, this project really highlights how in a participant's journey recovering from suicidality, their experiences are largely shaped by the attitudes and beliefs surrounding their suicidal period. There are some limitations to my project, notably that my respondents were self-reported about their experiences with suicidality, and they were all volunteers. It would behoove future researchers to use more diverse sampling techniques that could yield more generalizable statements about suicidal experiences. Because in this context, each of my participants uses the frame of their own sociocultural lens to describe their suicidality. In addition, the interview process allows us to draw conclusions only about the accounts of the experiences that my participants shared without understanding what really happened in these situations. Yet, I implore future researchers to use the implications and opportunities shared by these valuable and unique stories and narratives of suicidal experiences. It is my hope that researchers will continue to elevate the firsthand experiences through qualitative and mixed methods research that will guide and inform future suggestions for suicide prevention, intervention, and postvention in all types of communities around the globe. We have a lot to learn in the field of suicide prevention, and understanding those who have lived through it can be our best place to start. Here, I share a list of references that I used in my presentation. And here I share my contact information. I welcome your feedback, thoughts, and questions, reactions to the information I've showed here. I'm Taylor Binnix, and I hope you enjoy the rest of this conference. And I would love to connect with you down the line. Take care.